Welcome everybody, good morning. Thank you for taking time out of your busy schedules to join us today and to help our community. What we do is we share. I'm going to share my journey and my growth in attempts just to, again, give back to a profession and professions that I love. Our professions are prosthetics, prostheses, and dentures, and we love what we do. Number one, we don't slap teeth together. Woot woot. We do not do that. I'm very grateful again for you joining me and again trying to become that superhero for your patients, whether you see them directly or not. I'd like to thank Jim McGuire from VITA North America and VITA North America for their kind support of our professions and our growth as we again strive to become better. I want to take us down the road of immediate dentures and a little bit about them. They certainly are the most complained denture out there, certainly from a complaints perspective of complaints into professional organizations. We get a lot from immediate dentures because of their nature. I want to talk a little bit about them first, and then we'll go through a setup for it to just share with how I've tried to manage this. Immediate dentures are a large investment of time to not only make from the lab perspective, but also from the clinical perspective with follow-up care and adjustments. Every practitioner is going to have their own little way that they like to handle immediates and such. And I appreciate there's different ways to manage it, and manage it meaning how often you want to see the patient, whether you charge the patient for follow-up care or not. These are sort of business decisions that a direct care practitioner will make. My goal here is just I want to share a little bit of my journey and my knowledge just to help in terms of just helping you with, regardless of whether you're on the bench or whether you're a clinician, helping you with some of the demands and questions and, of course, complaints and problems that we see. So first off, number one, we don't slap teeth together. Whoop. Number two, everyone give a little whoop whoop in the office. Yeah, we don't slap teeth together. Number two, what we do is really hard. We have a difficult job because we have to replace natural teeth into an environment inside the body, which is subject to a lot of stresses and health considerations, and then it has to sit on soft tissue. Number three, there is a nerve into every natural tooth, regardless of its condition. When that tooth is pulled, that nerve is severed. So number one, the brain goes, hey, where did you go? That's number one. Number two then is the brain can't feel the teeth touch. So before they could feel the teeth come together and touch, and now that's going to, that one biofeedback has been eliminated. Depending on the state of their lower natural dentition, whether there's crowns or such, they may or may not feel the upper denture teeth come touch, but we can certainly say they're not feeling it from the upper perspective. That's really important to keep in mind, and I like to share that with patients. The nerve is cut, you don't feel the teeth touch together, or if you do, it's at a much reduced sensitivity than before. So it's difficult to know. So how will your brain know your teeth are touching? Well, one of the biggest things it's going to do then is after the tissue heals, it's going to feel the compression of the denture against the tissue. So it's much like your shoe. When your shoe's on your foot and you're just sitting there, there is a small compression of the shoe against the foot. So when you're just hanging out, there is a small compression or a hydraulic pressure of the denture fitting against the gum structure. Then when you swallow, your teeth come together to facilitate the swallowing process. The reason is that it needs a base to have the muscles come and brace against each other to facilitate that swallowing process. So it's a lighter pressure, but then your brain will know, oh, my teeth came together in what we would call centric in a swallowing perspective. That is a hydraulic pressure the brain will learn. Then when you eat, and you're eating, it puts down more pressure. And then your brain will learn, now I'm chewing, because it's like walking on your foot. You feel it. So then it knows, okay, now I'm chewing. So it's a different type. It's going to learn the hydraulics and the differences of the hydraulics. That takes time for it to learn that because it's a new sensation. Sorry, as I fiddle with the camera. It's a new sensation for it to figure out and to understand. The nerves externally on the outside of the mucosa, and more importantly internally in the fleshy part of the mucosa, take time to heal, and those nerve endings to heal to be able to accept the hydraulics and feel the hydraulic difference. So I really like to share that with a patient. The feedback that I get is patients are impressed when you take that time to explain how they're going to feel the denture, the sensations. Again, whether you're a technician or whether you're a direct care provider, this is important information to know, especially when you get into a trouble case and you're in the weeds, as we like to say. This is something that you can then share either with the doctor or you share with the patient directly to say, look, this took time, this takes time. It's kind of amazing. I'm currently 54 years old. I started caring for patients when I was 17. So it's been 37 years of my life now making dentures. And I really love what I do. And in those 37 years, you'd be surprised. People think that they can get their teeth pulled and run out and go to a restaurant and eat steak for dinner. It's kind of funny because you go to the hospital for surgery, you think, oh, okay, I got to kind of calm down and rest easy and such. But it's funny when they get teeth pulled and a denture put in, they think that they're just going to run around and start using them right away. And it's am I right? So it's been an interesting perspective on that. So I've really taken the time clinically to say to patients, you have to appreciate, number one is that outside of the tissue has to heal. That takes, say, 2 to 3 weeks. It's like if you cut yourself, it's like a wound and it has to scab over and heal. But then internally, does it take time? And that's that 3 months or 6 months of healing time for those nerve endings to heal, and then for you to be able to hydraulically load the tissue and load it substantially enough that you can be able to facilitate chewing. And then your brain has to interpret, the central nervous system has to interpret those impulses to understand what it's doing, because it's a new sensation to learn. How do you learn? Time, practice. And that's the big one, is that it takes time to practice again. It's like going to rehab or to therapy. It takes time to learn how to, again, learn a new process and learn something new. So I like to say that the number one overall mission statement in our office, or my office, is quality of chewing life, and then quality of life underneath that, because you have to eat to live. And so this in your mouth it's a mixing tool. So you take in food, you mince it. So the job of the teeth are to mince the food into a fine paste. Your tongue's there to roll it and mix it with saliva, stick it together, create that ball or a bolus, and then you swallow that down. So it's mince, mix, swallow. So I said to a patient, this job, mince, mix, swallow. And that's what the denture is going to help you to do, mince, mix, swallow. Just remember, the denture sits on soft tissue, so it's movable. And if you want, you're going to be able to sneeze and dislodge the denture. If you take your tongue and push on it, you'll be able to knock it out probably. It's like glasses. If I shake my head hard enough, they're coming off. If it's a hot, humid environment and you're sweating, they can drop. It's the same idea with a denture. So it's really important that you can take the time to educate. And something from a lab perspective is you can put together a tip sheet just with some high level points about, welcome to your new denture. And these are important things. Remember, your job of your teeth is to mince, mix, swallow. This is going to be a new process to learn. You learn by time and practice. Don't expect to eat the hard foods right away. You'll be on a soft liquid diet for at least several weeks, and then soft foods after that. And only at about month 2 or 3 can you expect to eat some harder foods. Expect follow-up care. Understand that there's no nerve into the denture teeth for your brain to feel it. It feels by pressing the denture, pressing on your gum. That hydraulics and that time takes time to heal. So there's already a tip sheet that you can do with 10 to 15 points. Give it to your doctor to hand out to the patient so that they see it, and then you're helping educate not only the doctor and the staff, but the patient. And that's, I think, a good plus for the lab from a marketing perspective and from a care perspective, because you're going to see the denture back when it's doesn't work or it's been relined for the 50th time. And that's expensive, and we're trying to cut down on those adjustments. And as a direct care provider, I also hand out that tip sheet to my patient directly, and I have them sign it so that they understand we went through and talked about this. So I wanted to, again, take a few minutes to talk about that, about what I do, and again, how your central nervous system and figures out how to use a denture, and what I like to call denture integration into the body. So those are some big tips that, again, have been effective for me in educating the patient, but setting reasonable expectations of what's coming. And I always like to write, this is a significant change. So you have to warn people. And change management is hard. It's hard on all of us to accept change, deal with change. And again, as we age, it gets harder to adapt to change as we get older. So I write out a tip sheet. So again, I wanted to sort of share that with you. You can watch the video back and pause it and go through those tip points to draft your own tip sheet. That tip sheet has been invaluable to me, because if I ever need to, I can always pull it out of the chart, circle back to the patient and go, okay, remember we went through this, and then we talk about it. And I always like to say, I appreciate your open communication of your concerns. And we went through this about, remember, it's the central nervous system, there's no nerve. And again, it takes time to understand the pressure and the hydraulics. So that's important. Okay, so I wanted to share that little bit of, 15 minutes here regarding the denture integration into the body, and how the body and how I've seen the body adapt to the denture and figure out a denture. So you get a case in and you're going to say, okay, the upper teeth are being pulled. There's a couple of things that, regardless of the condition of everything and the condition of the teeth, they tell a story. So you can tell a story by it. So how do you read the story? Well, there's a few things. One, if their teeth are really worn down to nubs, you know that they've really put things off. They've resisted change. They've resisted fixing their natural teeth. That's why they wore them down to nubs. And now they're going to get a denture. And right away, you know that, okay, well, the vertical is going to be opened. It's going to be thick. Their palate's covered. This is going to be a really hard transition for that person to get used to. So you can already see, just by the models and never seeing someone, a little bit about that person, but then some of the challenges that they're going to face trying to adapt to the denture. The other thing that I want to point out is you also can look at the teeth, and the teeth themselves can tell a story. So what you want to do is you want to look at them and you want to see wear patterns. So you can look at, say, the individual teeth, and you can see, geez, is there a wear pattern here? Because on the articulator, you can move it and I can see, look, there's a wear pattern. So specifically on the edge of this incisal edge of this cuspid, there's a wear pattern to the incisal edge of the lower cuspid. So what does that tell me? Well, that tells me that the jaw's coming out in a chew cycle, and we have canine guidance. So what that's telling me is that it's telling me how this person chews. And it's telling me then I need to pay attention to that, because I can mimic that on the articulator. So there's a couple things that I want to point out. Everyone has a chew cycle. So a chew cycle is how they physically chew their food. Some people chew very vertically, some people chew very horizontally. It's like a fingerprint. And so by looking at a model and seeing that wear pattern, even just specifically to these two teeth here, it tells me a little bit about that pattern. Then I can manipulate an articulator. So you've already saw me do it, and now I'm gonna focus in on it. I don't do this. So you know how you open up an articulator and you just, let me go here, there we go. And we just do one side at a time. That's what we typically do. What you saw me do is I opened up both sides of the articulator. Even if this is just a hinge articulator, it doesn't matter. You can hold it and you see me do this. So I'm moving the articulator like a chew cycle. And then what I'm doing is I'm trying to line up those wear patterns that you see here. And I'm going and I'm now looking and going, well, geez, look at their chew cycle. So when I set up the denture teeth to the natural occlusion, I'm going to remember that cycle to mimic it, to again then adjust the denture teeth to follow in the chew cycle of this person. So I can already see wear patterns on these two teeth here on the laterals. So that's telling me the nature of the chew pattern. There's a lot you can look at from a model. If they're worn down to nubs, it's the same thing. Then you try to facilitate the nubs, and you try to facilitate where that pattern is, and then mimic that pattern when you set up the denture teeth. So that's been very effective for me in terms of trying to identify the pattern so that the denture teeth then operate within the same environment of what the natural teeth once did. Because there will be a muscle memory pattern, a nerve pattern, and that pattern doesn't go away. So this is something that you can just quickly look at and ascertain by the models, by what you're looking at and rehabilitating. The other thing I just wanted to mention is that, especially in cases where the teeth are worn down to nubs, you got to be careful how much you're opening the vertical on the case. You got to be careful. We have an unconscious bias, in my humble opinion, to freeway space, that we always are looking, 2 to 3 millimeters of freeway space clinically. You have to remember it's 2 to 3 millimeters posterior, 4 to 6 anterior. So that 2 to 3 is always in a posterior, and that's harder to see. We unconscious bias ourselves into 2 to 3 in the front, which is then even less in the posterior. So you have to watch and be aware of that. And sometimes it's best not to drastically open a case, but that's another topic for another day with videos and understanding. But at least here you can, again, see the pattern, start to move the articulator within that pattern. Because again, what you're trying to do is have that understanding that that patient can't feel this thing. It's only going to feel it on the tissues. So now you're trying to just give it a better working pattern and better integration as it moves forward, okay? And as the patient moves forward during their adaptation period, okay? All right, so let's make some noise. Okay, some of the unknowns. Thank you for sitting going through the noise. All right, some of the unknowns for us. Number one, we don't know how surgery is going to go here. It's quite possible when the dentist is pulling out a tooth, some of the bone or the shelf of the bone comes with it. We don't know these things. We don't know how the pull's going to go. So in the lab, when we do this, we typically try to, again, take the root out, do a little bit of impression just to facilitate a little bit of pressure to in terms of helping create a little bit of a pressure over the socket to facilitate clotting. You want to just make sure that you knock any collars down and that things are smooth in here when you're done. Sometimes people leave quite large divots in here. I'm not a fan of that personally. I like to go a little bit more on the shallow end of things. That seems to have worked better for me. You can certainly see on this model, there's a really strong cuspid eminence here and bone, and we know already, wow, that is going to be a problem. So most likely on the final denture, we're going to have to try and probably trim it a little shorter and relieve it with the understanding of we're going to have to just let this area heal. It's possible too then that you can have a discussion with the doctor to say, okay, it's a really strong cuspid eminence. Is that something that we can also correct from a fit perspective? So you can open in on those discussions, again, just by looking at the model. So I've taken the opportunity here to quickly remove the 3 teeth here. The other thing that I want to point out is, as we get into it, that today I wanted to spend time on the mechanics of things, with the preemptive about the nerves and the denture integration into the body. The other thing that I want to point out is, here's the cuspid, and here's the long branch rugae of the patient. So the long branch rugae, let me just get focused up in here. So might be a little hard to see again, but you can see as I turn the model, the rugae, and that long branch rugae is the first rugae. That points to the cuspid. So you can see how the long branch rugae comes and points to the cuspid. And it's the same on this side, is that long branch rugae on this side will point to where that cuspid just used to be, where I just took it and ground it off. So I'm gonna do a really terrible job, but do the job of kind of penciling that in so that you can see it from a video perspective versus an in-person course, which would be easier to see it. But you can see sort of the reflection and the rugae here, and the rugae comes up, and it's what the rugae does is the long branch rugae points to where the cuspid is. This is good because then I want to follow that regardless of how things go. I know then that once the canine comes into this position, the rugae is pointing at it so that the tooth is in the same position of where that natural tooth used to be. That's super duper important from a golden proportion perspective, because everything in this mouth, everything on the lower, everything in the skull is all golden proportioned, which means it's mathematically equated to each other. So you want to make sure that again, the biggest thing that I pay attention to is just that the cuspid is where that long branch rugae is. That's golden proportion for everything else that comes into play after, meaning everything is mathematically equated and will work from a mathematical perspective, as well as, geez, he looks like a hockey player. Looks like, and then from a functional perspective in terms of the chew cycle. So remember the chew cycle. Now that we've removed that cuspid over here, we're still left with the wear pattern here. So we'll know then when that denture tooth comes into play, that's how that person is chewing, so that I can mimic their chew cycle. So that's really important. I, again, use the articulator to my advantage. Instead of just what we were taught in schools per se, I like to now mimic and open it up and really start moving the articulator to my advantage. That was a real game changer for me when I started to do that, was to try to, again, make things, have the articulator help me. Geez, I sound like Jerry Maguire. Help me help you. Have the articulator help me mimic the chew cycle and mimic so that I can set the teeth in a better dynamic so that they work. Because remember, the patient can't feel it the same way. They can't feel that there's a raspberry seed stuck in the upper teeth now ever again. They don't feel that anymore. And the more that I can be aware of that and help them out, the better. Okay. All right. So we're going to get some wax, and we're going to set some teeth up here just in the anterior, and then carry on to the posterior. So you all get to see me work, so this is good. I'm earning my keep. Typically, I just like to use a small pea size of wax. I don't like to, lots of wax gets really messy. Again, I'm going to make some noise. Because I do have to grind the denture teeth. And I'm setting this up from, again, today's lecture is based more on a traditional sense, where we're doing this the old-fashioned way and not a digital way. In the future, as we move to a digital, it's the same idea in terms of scanning this and then taking out the natural teeth and then super laying the denture teeth on top. You want to be aware of those patterns and those chew patterns. That doesn't go away. You still want to do that in a digital aspect. Follow it up after, in the mouth after digitally, to make sure that your bite pattern is where it needs to be. Because again, a virtual articulator, I can't do this to a virtual articulator. A virtual articulator only does what school taught us, not now what I like to do in mimicking a chew cycle, so that we can still use that and still use the technology, just then I have to follow it up in the mouth afterwards to watch that patient's chew cycle. I've made note of the wear patterns and then make sure that the denture's following in that same type of spirit or same type of denture integration. So regardless of whether this is a conventional or whether this is a digital denture, same rules will apply in terms of identifying the chew cycle, the wear patterns, so that you understand how this denture is going to work in that patient's mouth. Now this circles back to, and I'm just going to go off topic slightly. Patients come back and typically what they'll say with an immediate denture is they'll come in on an adjustment and they'll say, I can't eat. And you're going to say, what do you mean I can't eat? Well, I can't chew. I can't eat. It's not working. It's not working. And when you ask somebody, well, can you be descriptive and tell me what that means to you? They have a hard time. They get a little frustrated and they say, look, it's not working. I just can't bite. I can't bite. And then you look at the centric and go, well, the centric's great. My bite's right. What do you mean you can't bite? What you need to again remember is, what's the function of the teeth? Mince, mix, swallow. During that mincing, they're not mincing up and down, they're mincing in a chew cycle. And that's like a mortar and pestle. The food stays on the bottom teeth. The bottom teeth is the bowl that brings the food up to the cusps on the upper, which would be the denture, to mince it. That's the process. And so if they are having trouble doing that, then you know that they're not chewing in centric, they're not chewing up and down. There's a problem with the cycle, and then the teeth are interfering and they're click-clacking around, but remember, there's no nerve into the denture teeth. They can't feel it directly. With emphasis, they can't feel it directly. So then that's when you need to click in your brain to say, they're having a problem. It's the cycle. And then what you can do then is you'll have to free up the cusps and make the denture work more to their cycle. That's why they're having trouble with it. It's for that reason. So that reason is, again, it's not that they can't touch together in centric. It's when they're using it within their own chew cycle, the teeth are not binding or collaborating or integrating properly. And that's when the issue lies, and it creates an interference in the denture, and the patient cannot then chew. And then that's why they end up in your office and say, I can't eat. So remember, it's the mince, mix, swallow, and then they're doing it not in centric, but they're doing it in a chew pattern. So that's how you can start to decipher that. Okay, I'm gonna make some more noise and I'm gonna take some more teeth off. So bear with me. So again, I've taken the first premolar or first bicuspid off, and again, just trimmed a small divot into the socket where it was going to be. What I'm doing is I'm just trying to generally follow the incisal edge around. And then now with the chew pattern, I remembered what the chew pattern was. So the teeth are falling in. We've marked out the rugae. So it's telling me remember where the cuspids used to be. So I'll uncover some of that from the wax. All right. So it's just helping me guide so that the denture teeth go back into the same position from a golden proportion perspective. So because then that also sets it within the parameters and the skeletal parameters of the patient's chew system. More noise. Okay, so we can see then that the cuspid's going to line up in terms of where the rugae was. And then I'm going to just put that into position, get it back under the camera for you. And now I'm going to do this, and you can see now that the wear pattern does not line up. So remember when we first did this, there was a pattern, and there's a divot on the bottom, and now there's no divot on the top. And what you're going to see is because there's no divot, that's going to interfere. Because there was a divot on the upper and there was a divot on the lower, we knew there was contact there, or a cuspid relationship when the person was chewing. And now if you go through that, it's going to bind. So then now I know, okay, wait a minute, I need to correct this because it was there before. If I don't put it back into that same position with that wear pattern, it's going to hit and it's going to start knocking the denture out. And then what does the patient say? The patient says, I can't eat. So I'm going to come in and I'm going to tilt the tooth a little bit. Okay. And I'm going to gently put in that wear pattern really carefully. Where it was on the anterior tooth before it came off, or before I removed it from the model. And then what I'm going to do then is I'm going to put it, and now you can see that the wear pattern lines up. Now I adjusted it very carefully, so cosmetically you're really not going to see it from the anterior perspective. In this case, I can go then, and then you can, it's again kind of somewhat hard to see, but it lines up right there. The two wear patterns line up, so that then when the person's going through their chew pattern and cycle, then it's not going to hit and cause that interference and dislodge the denture, buckle the denture, or just prevent the chew cycle from completing. And that's when the patient has the issues of I can't eat. So that was something that, again, from a technical perspective, I wanted to again bring to everyone's attention and share that. That was something that, again, was an aha moment for me of, again, looking at the models, looking at the wear, and then you're trying to mimic, include, manage, become aware, incorporate that pattern into the denture as you're completing it. Now, again, as a digital technology continues to evolve, we'll be able to, again, put that wear pattern into the digital aspect of the tooth as that technology improves as well from that. But that's how you want to, again, be aware of it. Again, if you make the denture digitally, you'll just have to do this manually after it's completed to put that little wear pattern in, because again, you know that the patient is going to be chewing like this, chewing like this regardless. So that's why I put that little pattern in. Okay, I'm gonna make some more noise. Just a lengthy time. Okay, so I've taken off the second molar. I want to point this out. Typically, and this is decent because the teeth are in still decent condition from a wear perspective. This is the lingual cusp. This is the lingual cusp. Those lingual cusps fit into the corresponding fossas of the lower in most cases. And so even though there's some change or whatnot, this is a mortar and pestle approach. All natural dentition started out as mortar and pestle. Then, of course, it changes and is altered through the course of a person's life. And if they wear their teeth down to nubs and stuff, they change the mortar and pestle approach, but it's still there in some way, shape, or form. So that when I rehabilitate them, though, you're going to rehabilitate to the mortar and pestle, not a 20-degree milling. This is important to remember, and again was an aha moment for me, is especially on an immediate denture, and especially as things might be quite degraded in the mouth at time of extractions, you have to appreciate you're rehabilitating that. You're going to change it, and you're going to change it back to what it once was many, many years ago. That's the point of the rehabilitation. Okay, so I wanted to bring this just because, again, we're going to be following this point in a moment. So I'm going to make some more noise. All right, so let's carry on. Okay, Jim, if you're listening, are there any questions yet that I can answer while we have a little bit of quiet time between me grinding?
Yeah, when you, the question is, when you do grind your natural tooth nubs or the tooth form off the model,
Yes.
do you ever create a socket?
A little bit of one. Yes, gently, a little bit. Many years ago, I used to do that quite pronounced, and I found actually that caused more problems than good afterwards from an adjustment perspective. So I do, yes, is the answer, just very, very gentle. It's hard to see here, but you can just run your hand over it. You can just feel the little divots of where it used to be. Go gentle on that, because again, this is going to clot over, and again, you don't want to put tons of pressure on it and blow the clot. I also, again, you get to know the dentists and get to know a little bit of this and their style of pulling. I always make sure that I have my secretary phone the doctor's office the day or after the surgery to say, how did the surgery go? Was there any problems? Did any pieces of bone break off? Was there anything, that again was an issue? And they know to expect that phone call from us now, and they can say, no, it was straightforward, regular stitching, everything was good. And then the doctor knows to also make those notes for us, because I want to know if there was a problem when he pulled and some of the bone came off and he had to take more of this away or whatnot. So again, roundabout answer to the question is yes, I do little divots, not large, and then always follow it up afterwards, because again, I'm going to be seeing the patient in short order. I want to know how the surgery went. Next question, Jim, if there's one.
We have, you mentioned 2 to 3 millimeters in posterior to open up, 4 to 6 anterior for free space.
Yes.
What's realistic? I mean, what's the maximum you think? I know it's individually patient tolerance, but I guess the question is, what's the maximum or minimum one can do safely go? Or is that it? 2 to 3 in the posterior and 4 to 6 in the anterior. That's it.
I'm all dusty. That's a great question, and it's such a subjective question. Hang on, there's dust on the lens. I sound like a country song. There's dust on my boots, and okay. That's a subjective question, but let me try to answer it this way. from a high level general perspective, if a person wears down their teeth to nubs and they're really broken down, then how are they eating their food? And say they're missing teeth and stuff. Well, they're having to mill it, and that means that the chew cycle has gone more horizontal. That's why the teeth are worn to nubs. So then they're going to be quite overclosed. And then again, we have the subconscious and unconscious bias of we should open that up to the textbook, and we have the 2 to 3 millimeters. So if I would have canvassed everyone and said, how much freeway space should you have? And everyone's going to go, oh, 2 to 3 millimeters. And then when I stop and say 2 to 3 millimeters measured where? And then everyone goes, because we forget that should be measured posterior, and that's backed up by articles and such. It's actually 4 to 6 in the anterior on a healthy, normal dentition. As this deteriorates, we're going to increase the vertical, or increase the freeway space, pardon me, so that patient has more. So then the practitioner is going to want to correct that. And that's where we get into troubles, is that you have to remember now, they're used to a milling pattern. Now you've set denture teeth that are made to more operate in a teardrop pattern. So that's the first thing. You've cut the nerves, they can't feel it. They're going to want to go back to their more horizontal chew pattern. You've set the denture to go a teardrop pattern. So there's discrepancy number one. And then you've really opened the vertical. And then that becomes that, oh, they feel so big approach because, well, yeah, they have to be. That's a real struggle for someone to get used to, because again, we're changing a lot, and there's a lot for that person to adapt to when they can't specifically feel things. It helps in your adaptation when you can feel your way through it. When the nerves are cut and the dentures put on that gum, they don't feel it the same way. So on those cases where you have the nubs, I'm going to leave it more overclosed from what the textbook would tell me to do. I'm doing that to, again, for denture integration into the body, patient acceptance. They need to be able to, again, mince, mix, and swallow. So in those cases, I'm more inclined to leave things overclosed because they've been overclosed for quite some time. They're used to that overclosing. Because I can see the patient directly, I'm going to check to see if they're symptomatic being overclosed. So that's really important. If they are not symptomatic being overclosed, then you can, alter it somewhat, but leave it on the overclosed end. If they are symptomatic being overclosed, then you need to correct that. And then that's your judgment call on how much correction. So it's a high level response from me. If I find that the dentition's really worn down, I tend to be more conservative on how much I'm going to open the case. I'm going to be very, very cautious because of just my experiences dealing with people. You don't want them back in your office for a lot of adjustments. And if you crack that thing open to 2 to 3 millimeters of freeway space, they're going to be back a lot because you've changed those two dynamics for them. Remember the chew pattern and then just the general height. If their dentition is more, reasonable and things aren't worn to nubs and it looks like, the vertical was kept, then I'll keep it more into that where they are, which is probably that 2 to 3 millimeters of freeway space posteriorly. I bring that up because I want to address our unconscious bias to freeway space, and that we are typically missing it. And again, you have to look at the person and look at who they are. And again, this is outside the realm of today's topic, but on future topics, we can talk about it, again, as their face sags, it's going to pull their jaw down, the muscles sag. So freeway space actually gets more as you get older because the muscles are losing their tone and it's opening the jaw more slowly. And then we come in there with good intentions, but it's the wrong good intentions. So to roundabout answer your question, that's my answer. Conservative if it's the nubs and I really know, and then a little more towards our 2 to 3 millimeters posteriorly on cases where I don't think the vertical has changed or altered a lot before we build the denture. Okay. So bear with me. I need to just grind a wee bit. Thanks for those questions, and thanks, Jim, for, well, it's nice to answer those questions as we're moving along. Again, the mindset on this and the rationale and the reasoning is denture integration into the body, but managing the amount of adjustments that patient is coming back to your chair afterwards, because it's very expensive and time consuming. The more the patient's back, you're not making money when you're dealing with these after post-insertion adjustments. I'm trying to get it and deal with it on the front end, meaning before we start, before it gets inserted, so that I control and can manage the post-insertion adjustments and the time involved after the fact and the complaints that come after the fact. And that's what I'm sharing with you today, is that journey and interpretation, because that's really where the trouble lies for us, is again the eating up of chair time, which is extremely expensive on a practice, and what you can do from a lab perspective to help that doctor manage their chair time so that they're more productive in it, because you're building the denture more integrated to that person. And I've already given you as I talk over the fan, I've already given you some tips of what you can see in the model, and then how you can just even deal with this in the lab, on a lab perspective. Okay, it's actually quite fascinating what you can learn from just looking at the models of the teeth and the condition of the teeth on the model before you start taking them off and building the denture. And that's going to help. It's going to help the integration. It's going to help the adjustments. It's going to help ward off the complaints. And this is good because you're managing the chair time. And then from the doctor's perspective, it's like, oh, my lab builds good dentures. I don't seem to have troubles with them. That's why, is because now you can deal with this in the lab, like we're dealing with it right now, to help the future person to adapt to this. Now, this is what I do. So remember how I showed the red earlier? So now what I'm going to do is I'm going to take a red pen. So this is a non-permanent pen, so you can use a Sharpie, or this is a Stapler, made in Germany. Stapler pen, so they're non-permanent. And what I do is I color this, and then I'm going to tap, tap. And then what it's going to do actually is it actually moves the color away from the tooth. Going to be a little difficult to see here on a video, but you can see it's missing. And then again, we're going to have the red dot here on the natural tooth, which is right there. I do not use articulating paper. Let me fetch some. I do not use articulating paper anymore. And you're going, what? And I'm going, nope. Because when you lay articulating paper, regardless of how thin this is, when the teeth come together, it cracks and crinkles and it bends the paper. And I appreciate you guys are busy in the lab and such, and you're trying to get through these cases. So you go tap, tap, and you grind, 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 grind. When the paper bends, it can give you a wrong reading, and it's not accurate as the cusps are coming against the fosses and how this thing is bending. I have found it, again, more fine and finite when I use these pens to quickly color and do it for me, because now I'm only getting the reading that I need. I can also adjust this and grind this quicker because I'm now not having to deal with erroneous marks that the articulating paper can give. And then again, This is an effort to have this thing fit and function and integrate into the body better, so that I'm not hacking it, because remember, we don't slap teeth together. So what I'm doing is I'm setting down into centric, of course, but now I'm going to do the chew cycle. And then again, this shows me if it's pushing the ink off or rubbing the ink off. And again, from the model perspective of the bottom, whether or not there's any marks down here on the lateral that's here. So this has been, again, I'll call it a game changer for me, switching off of articulating paper, because of course that's what we were all taught to do and have become accustomed to. And I've taken some time to sort of retrain, I guess I'll say retrain myself, because I find that the pen works better. I'm quick with it. With the understanding of I'm rehabilitating this to a mortar and pestle chew cycle, because that's what we're doing here with an immediate denture, is I am reintegrating that patient to what they once had with a mortar and pestle type of approach. Teeth, okay? And again, you can even see it from this angle, it's hitting right there. So that's the only thing then that I have to adjust. From a centric perspective. Okay, so it's teaching me, see, now it's just hitting on the lingual aspect there. So the goal then is that this lingual cusp comes to rest, and you can see the red mark right there. So let me focus in on that for everyone, and let me bring it down a little bit better. So it's starting to focus in here into that lingual fossa, the distal lingual fossa. That's where that cusp is going, okay? So the other thing that I am not doing is grinding this into knuckle tight. I don't want this knuckle tight. I want spaces and gapping there. This has to do with that mortar and pestle approach. The lower's job is to, again, bring the food up to the cusps to get pulverized, okay, minced. So it's doing that in a cycle. So the bottom fossas are there to lift the food up. The guiding planes of the lower is there as the bowl, like a soup bowl, to hold the food as it gets crushed against the upper lingual cusps of the teeth. This is more effective, and this is how you're rehabilitating that person into their chew cycle again. So typically, I'm careful not to try and grind down the lingual cusp too much if I can help it. I'm trying to adjust the guiding planes, so it's in from a centric perspective. But then again, as I lift the articulator and I start moving to that chew cycle, and then I'm emulating up where that wear pattern was, because that's how that person's going to chew. And then I'm looking to see, and again, I need to color up into here now. I'm looking to see then how that tooth goes and functions within that pattern, because remember that pattern will be reproduced by that person because that's not changing. And then I can look. And then I can adjust as required. And you can even see it down here. Okay, let me grab. So there's the wear pattern right there. So then that means I need to be careful and adjust the tooth right on that line there. So you can see how I'm less, I guess, I don't know, I'm gonna use the word clunky with articulating paper, more finite with the pen in terms of the ability to, again, alter and change and adjust the tooth into position. Because really what you do here matters in terms of how it's going to function in the mouth and within that cycle of that person. So I hope that I'm making myself clear through my experience of that identification. Okay, bear with me, I'm going to make some more noise. Okay, so I'm getting ready to set the upper molar on the patient's left side. Into position. And then again, I'm going to do the color. And then this just wipes off with Kleenex, a wet Kleenex. You don't even have to polish it off. It just comes off underwater because it's a non-permanent pen. Please don't use permanent. Okay, so already you can see this was very similar to what that natural tooth was in terms of already arcing and how that tooth looked. And then again, I'm just doing my original and first centric. And you can see now how there's the little red dots are starting to develop here on the tooth, here and here and here, and there's one even within the fossa. Again, then I can see that it's hitting here on the guiding plane right there, hitting here on the guiding plane, and hitting here on the guiding plane. So now the guiding planes of the upper need to be adjusted and widened because remember, this upper denture tooth was made to fit its corresponding lower denture tooth, not a natural tooth. So this is where the customization has to come in from you. And then again, in a digital perspective, it's the software trying to figure that out. And then you have to, again, guide the software and help it understand what it was interpreting. Couple things I want to be clear. Remember, software was developed by a software engineer, not a dental person. It was a dental person telling the software engineer some of the semantics of what we do. But dental people don't know how to write software, and software people don't understand dentistry. So that's where we kind of have to have that coordination from us. And then you need to understand the limitations of the software. So remember how I talked about the chew cycle? So we lay it into centric, and then now I'm going to open, and now I can do this. Again, that's going to be a little tougher to do in terms of the digital aspect of this. And so then I'm following up to that wear pattern that I knew existed. And then again, you can see, look, there's a wear pattern right there. Okay, and then on the bottom, it's hitting right there on the guiding plane. Okay, so what it's doing is I'm getting the tooth into position, but I'm not having to adjust a lot of it away. I'm still leaving gaps and spaces in here because again, you don't want this knuckle tight, because if this is a knuckle tight scheme, it pushes the food out. You need the food to be able to stay there to get minced and crushed. If everything is so knuckle tight, you think, oh, that's helping. It actually is not, because there's no gaps. Everything's just getting pushed away. It has to be able to stay on the tooth as it's getting minced. It has to be able to stay there for the teeth to do their jobs, because the food has to stay in the fossa of the lower to get minced by the upper. So I'm leaving the occlusal scheme more open than what I did 25 years ago, where I was taught to, no, you make that tooth and you make it touch really tight. No, please don't. Because then that really was why the patient was back in my office every 3 days, tying up my chair time, complaining, and me shrugging my shoulders going, it's an immediate. What do you expect? So this is something that we're just trying to get a better hold of and address ahead of time, because those conversations are difficult to have with people when they're in your office mad. And all the direct healthcare providers on the webinar with us will understand that. People get upset with you about why things aren't working. Okay, Jim, how are we doing? Any more questions coming in? I can answer one or two here while we have a little bit of quiet time.
Yeah, so if there was overgrowth of bone due to heavy contact in the natural dentition, do you ask the doctor to shave it down during the extraction?
A lot of times, yes. Yes, if you foresee that to be a burden or a barrier for the fit of the denture, yes, you should have it removed, because you know it's going to be an issue later on in terms of the hydraulics that the denture is going to push on that bone or that overgrowth of bone, because let's face it, there's not a lot of padding over that. So the answer is yes. If you feel that's going to be an issue, you have it taken care of and ask that it be taken care of. It's going to help the fit of the denture and the fit regarding the hydraulics that the denture is going to place and exert on the tissue in the future. Another question, Jim?
Okay. Yeah, what if the antagonist has teeth that are worn flat? What do you recommend when using teeth with anatomy?
Okay, can you say that again, Jim, because you broke up a little bit due to the internet connection?
So basically, if the natural teeth are worn flat, do you still use anatomical posteriors on your immediate denture?
Yes. So the answer to that question is yes, as much as possible. But so the but lies with. Okay, Jim, I'm getting a lot of reverb. So can you just mute yourself and then I'll answer the question. Thanks, Jim. Okay, oh, that's way better. Thanks, Jim. Let me just demonstrate on this, okay? So what I'm gonna do is I'm gonna wear down this lower tooth and then I'll talk about it, okay? All right, awesome. So what I did was I wore down that lower. So let me just grab a piece of paper here. Bear with me, everybody. Okay. Again, really good questions. Okay, so right now I'm dealing with a lower tooth that's got some anatomy on it. So then when the upper tooth comes in, I'm just placing that upper tooth in and I'm just making sure that this lingual cusp fits within this. Okay, so that's what we're doing right now. Okay, so now to answer the question specifically, as the lower gets shallower, so let's say it looks like this. So as the bowl becomes shallower and doesn't have as deep of a bowl, it's a shallower soup bowl, then if I come in with a cusp, it's going to pinpoint. That's really, what does that serving mean? Not much. So then I have to take that lingual cusp and I start to flatten that upper lingual cusp down. So again, if the bowl becomes shallower, then what I'm doing is I'm taking the upper lingual cusp of the denture tooth, of that anatomical tooth, and then I'm shallowing that cusp down, loosely drawn like this, okay, so that it becomes a bigger, so the mortar and pestle, it becomes a bigger, I think it's the mortar is the cusp. It just becomes wider to fit in this. So I'm always trying to facilitate that. Remember, that person's going to have that chew cycle. The job of this lingual cusp is to mince the food. So let me demonstrate that now here. Because the lingual cusp now of this upper is pinpoint because it was made to fit against a denture tooth. Now I've worn down this surface to as basically what I just drew it for you. So now I can already come in here knowing this even before I color it in red, and I'm going to dumb down that lingual cusp and flatten that down a little bit. So you learn to kind of eyeball it against the shape. So then I'm going to color. And then I'm going to come in with my centric. So then you're going to have to take some time to okay. Sorry for the noise, everybody. So that's how I handle that situation, is I try to leave things as anatomic as possible. And now all I've done is I've gone in and I've actually just, it's going to be a little hard to see here. Let me focus. But I've gone in with that denture tooth here and I've just taken and I flattened out that cusp, which is sitting within that flatter bowl as I drew it out for you on the paper. And that's how I handle this. What we want to keep in mind, the buccal cusp is the shearing cusp. This should overlap the buccal of the lower, because what it does is by overlapping it, it helps keep the food while you're going through the chew cycle. That shearing cusp helps keep the food on the table to get minced by the lingual cusp. And that's the job of the lingual cusp of the lower as well, the reciprocating shear cusp, pardon me. As the bowl gets flatter, we don't have that same shear cusp because things are flatter, so the food has a tendency to come off the bowl quicker. So that's why I'm trying to, again, leave the shear cusp here to help keep the food while the patient's going through the cycle, keep it on the lower to then get crushed by this more flattened pulverizer, the lingual cusp. Coming back to our document here. So as I've shallowed this out to fit within the shallow bowl, I want to leave this overlapping because, again, as this cycles through, this job is to kind of keep the food coming back. It helps hold the food and keep the food coming back to get in here to get minced, so it's more efficient. I want less chews, more efficiency, less hydraulics, better fit. And so I rethought this is again, even though this is shallower, the food might slip off quicker. The tongue's job is to get it back on, but at least I can deal with it with this shearing cusp here if this shearing cusp here is flatter. So I hope that answers your question of what we do now on a flatter tooth. It's the same principle, but altered now to fit against that flatter tooth. Because now I've taken this down. And again, that's why I like to use the pen to help draw this for me so that I can see things clearer. I don't want it knuckle tight. I want the gapping. I want the overlay of the buccal cusp over top of the buccal of the lower, because again, this is working in a chew cycle. And then again, I would mimic that chew cycle now that I've identified from the anterior wear, and now I'm making sure that this functions within that chew cycle. And you can see that it's not, because now I got a piece of stone on that and it got pushed away. So that's something that now we can correct, where that shear cusp was actually too stark or too prominent. And now I need to dumb that down slightly because it was hitting, whoops, you can see it hitting right there. So it was for this person's chew cycle, it was interfering. Okay, so that's what that shows me. So I'm trying to, again, set the teeth within a better, again, integrated denture integration of what this person will be chewing with and how they'll be chewing. Neat, hey? So now you can see there's a definite wear pattern on those laterals and even on the cuspid. Everything lines up. So I know then from this side, it was on those the cuspids. And now from this side, I know, okay, this is that angulation that this person's going to be chewing. And you know what's interesting about this? Let me open this up and show you. If I lock this and open this and do our standard typical movement that we would do you see how these teeth are not in contact? But there's a wear pattern there. And there's a wear pattern here, but it's off. So if I take and I open now the other condyle, and now if I do that same movement, you'll see again, it's not in contact. But if I let the articulator slide back a little bit, all of a sudden, do you see it drop into contact, contact, contact? So what happens is if I would set the teeth according to the articulator's movements, I would not have copied that wear pattern and that specific chew pattern of how the jaw's drifting when this person chews on this side of their mouth. This is their right side. Right side's dominant side for most people. So now what I know is that I have to let the articulator slide back a little bit. So I need to retrued it a little bit, and then the patterns wear up. So on this side, I didn't have to do that. It did it sort of within the realm of the articulator, but when they're chewing on their left, but on their right, there's a deviation now of what that's telling me with how the condyles are working, that things slide back a little bit. And so now when I set the teeth on this side, I need to remember that, let the articulator come back and set the teeth, and then I can check any contacts here as well. Isn't that amazing? It does not take a lot to see these little movements, so that then when this denture's done and crafted, it fits the patterns and the wear patterns and the chew pattern of this person better than otherwise. And then what does that mean? A better integration into the body. What does that mean? Less adjustments. What does that mean? Less complaints. Huzzah. Can I get a huzzah from everyone upside down? Huzzah. That's why we do this. We're trying to be that superhero. We're trying to, again, be a superhero to the patient, to give them something that they can mince, mix, and swallow with, but at the same time, control and deal with the repetitive adjustments that we see. And this is how I sort of came through this, through my journey, was I look and then I try to line up the wear patterns, and then that's how I'm going to set the denture teeth on this side, let the articulator drift back, let things line up a little better, so that then when this goes in, it's going to function better. Jim, any questions?
So as a follow-up,
Yes.
say, for example, if you are making a lower immediate,
Yes.
but flat ridge due to periodontal disease,
Yes.
and the opposing upper natural, then with healthy form of cusp, do you use the VITA aciniform or lingual form?
Lingual form. And it's all lingual form. And then all I'm doing is adjusting the guiding planes. Again, even if this is a flat ridge, that doesn't matter. Where the stability comes is this is going to be moving in a chew cycle. It's going to hit the upper cusp, and that's when you're getting the mince part. If you line this up correctly and you have enough freedom and you've ground the guiding planes away, it's not going to hit and bind and then rock the denture. So we used to go on the idea of flat ridge, flat teeth. That's not helping anybody, because how do you again chew with flat teeth? How do you drive with bald tires? You need to give them anatomy, give them the overlaps. Just you flatten this part out so that it works. And then that, because they're going to come in, mince, open, come in, mince, open. And because again, say it's a flatter ridge, the stability lies within how the teeth function within that chew cycle. That was a rethink for me, and a great question and a great aha moment for me was I always thought flat teeth, flat ridge, flat. No, everything gets done with lingual form. I adjust the lingual form to the needs of that chew cycle and that patient. And that's where I get the stability from, is that the occlusion works with how that person is chewing and that cycle that they're chewing with. That's how the success is achieved, and the reduction of adjustments and reduction of complaints is achieved is by me, again, setting teeth within the cycle. Great question. And that was a fundamental rethink of occlusion for me. And I had to get out of my way on that one. But now, even on a regular denture, I use so little soft lining material, I don't buy it anymore, because I don't need soft lining on a flat ridge, because it used to be flat ridge, flat teeth, soft liner. Not anymore. I want efficient rethink. This is a mortar and pestle, and when we go back and redo the denture, we're giving them mortar and pestle when we build them a denture. And the muscles will remember, and again, it works extremely well when you set within this chew cycle. You see how I drift it back? So I have to drift it back. all of a sudden the wear patterns line up, and that's how I'm going to set this right side of this patient so that I remember that. And then it's going to line up so that this works better, then I don't need the soft liners, and it's going to work from a perspective of the chew cycle. And then the benefit to that is I'm not chipping teeth, because now I've set them within the ideologies of that specific needs of that chew cycle, so that again, when they're chewing, these aren't hitting, because again, there's no nerve into them, they can't feel it. I'm not going to end up chipping teeth like I used to, because I've really eliminated the chipped teeth problem here. And that's why. That's been my journey, really closing in on that chew cycle. Great question again. Thanks, Jim. Okay, so let me make some noise. There is only a handful of mortar and pestle denture teeth designed on this planet. Lingual form is one of them. I think there's only like 4 kinds of denture teeth globally that have mortar and pestle types of analogy on them. And that has served me well, is to switch over to that mortar and pestle, not standard, 20-degree teeth, and to really get control of the adjustments, because again, you're switching a person back to that type of mortar and pestle. It's more efficient. So what I did was I just left the central to show how we're going to set the lateral. So bear with me, I just have to adjust the denture tooth here. There, okay. I'll bring this up into field of vision here, thank you. Okay, so I've ground off the lateral and the cuspid here. And so now again, if I just do a standard articulation movement, the teeth don't come into contact. If I let the articulator drop backwards, all of a sudden the teeth are now in alignment where they were before we started the immediate. And that's what my goal is now, is to emulate that motion, because when they chew on this side, it drops back a little bit and the condyles come back a little bit. So this is letting me now emulate that, and so that then I can gain that same pattern. Now you're going to say, but Mark, do you want to correct the turn? Well, I can correct any of the drifting and things, but what was really important and why I started here was so that I remembered and I can set that same pattern in place, so that when I set the cuspid, I can also set the same pattern, and then all the other teeth then will follow, because then I'm using this as the guide to, again, remind me of where that pattern is or was, and then that way then I can make sure that the rest of the teeth fall within that realm. That's why I do that. Does that make sense? So again, I'm going to, again, make a little bit more noise. And we're going to set this cuspid into play here. So I try to set the denture teeth, where I know the pattern is, so that then I can mimic that pattern. And then I'm always reminded of that pattern after the fact, and then I can set the other denture teeth to it. Okay, I'm going to grind the upper cuspid. Okay, so now we remember, drop back. Okay, sorry, drop back there. So now I'm going to take the red pen here, pencil. So right there, I got to do a little bit of customization to facilitate that wear pattern, or it's going to knock, and then that's where the chip can occur, especially if this was ever placed on an implant. So again, this is where the chip would occur. So I want to get after that because I know that that pattern exists now. And I can grind in here. Okay, so I'm going to take the opportunity to mention the material. So the material of the Excel and Lingoform teeth are made from acrylic glass. And when I adjust these teeth, I don't need to polish them again because they'll self-polish. When you adjust acrylic teeth, you need to polish them afterwards or the surface remains rough and then it'll abrade quicker because it's not polished. I do not have to do that, and that's the advantage of the VITA Excel and Lingoform lines, is that I don't have to polish this and take the time to polish the occlusion afterwards. It's a huge time saver for me. So now when I let it drift back, come into contact, and I facilitated that wear pattern, I need to do it a little more. There we go. Now it just lets everything line up, and I facilitated that wear pattern. But from a cosmetic perspective, you really can't tell because I adjusted it on the internal surface. So now what that's going to do is it's going to let this glide better when the patient starts to chew. And again, I'm controlling the fit and then any possible chipping. Isn't that neat? Awesome, Jim. How are we doing?
Doing just fine. So are we achieving group function is another question.
Yeah, so that's another good question. I love the questions. Okay, so from this perspective, we know that there's a canine guided function here because of the wear patterns. I'm facilitating that. Then I'm making this work. So the answer is it's a little bit of a modified group and canine guided function. So as I continue to set the denture teeth, so let me grab some of the articulating paper that I said I never used. One moment. Because I know what you're thinking. Okay, so if I come and I just move the articulator, am I getting working and balancing contacts? So the answer is yeah, there's some balancing and working contacts here. They're light, but they're there, okay? So with the articulating paper or shimmy paper, I'm getting them. But remember now, I have to drop this back on that right side because it circles back more. But yeah, there's contact right there. So yes, from the perspective of, and you can see where the cusps are grabbing it. So, you know, to answer your question is, I'm trying to set the teeth within what I believe is this person's chew cycle. So I've taken time to identify how I identify that chew cycle, try to mimic that chew cycle on the articulator so that the teeth function within that chew cycle. The next less important aspect is, well, do they really work in balance against the lower teeth? I'm not so much concerned about that because I'm more concerned with point one, which was, are they functioning within that chew cycle? Because that's how it's going to function in the mouth. Versus, well, do they really need to work in balance? Because this is, again, a mortar and pestle mincing approach. I'm making sure there's no deflective contacts from the guiding planes pushing it into position or out of position, because then that eliminates the rock on the denture. So when I said to you, it's kind of a mix of both canine guided and group function, it is, when you consider it through the eyes of, I'm setting this within that function, that chew pattern, that the teeth aren't knocking and gliding. So yeah, I'll get some working and balancing contacts usually, but I'm not so concerned about those contacts as I am about making sure that this thing works within that perceived pattern. Does that make sense? Again, it's a little bit of a stretch of what we typically do for occlusion and making sure that this thing works and balances. Because as you saw, if I would have done a straight working and balancing approach, I would have missed that wear pattern completely because it wouldn't have lined up. I had to let the articulator drift back, then it grabbed it. And that's what this person needed me to do. So I'm using the articulator to my advantage, helping me help the person. And so whether or not I really get working and balancing contacts, I'm more interested about anything interfering within that chew cycle so that this occlusion scheme can operate freely while this is working and the lower is bringing the food up to get minced against this. That's my answer. So it's the rethink and a stretch of occlusion, indeed. Another question, Jim? And I've showed you again what to do on a lower that's flatter and how we handle that type of situation as well. Okay, Jim, another question?
Can an X-ray verify the head of the condyle if it's worn, and may indicate that we cannot open too much of the VDO for long-term overclosed patient?
The answer is yes. The X-ray could, by definition, show if there was any wearing down of the condyle head, but you really need to see that in action. So it's one thing to say in that snapshot of time, in that position, does the head of the condyle look worn down or flatter? The answer is yes, but you need to see that person in function and moving. That's when you're going to really know how the condyles are moving, okay? Because obviously this is set to a 30-degree condylar angle and a 15-degree Bennett angle, and you saw how that then this didn't line up. I actually had to let it drift back, and so those angulations change. So on this patient, it's not symmetrical. And I was able to catch that through the wear pattern of the teeth. So now when I rehabilitate this thing, I'm using that articulator to help me. And again, that's going to make this thing work better. So the answer to the question is yes, it's going to help. Yes, it's another diagnostic tool available to you to see if that's the case, to help you learn more. Yes, any tool in your toolbox to help you assess a patient better is a good thing. Next question.
So right now, if anybody has any questions, go ahead and send them
all
in
right.
because we'll probably be wrapping up soon.
Yeah,
So,
we're
uh,
we're
it-
we're getting to the end because I wanted to show the key points. Like, I'm not so much concerned about taking all the teeth off. Like, what was really important here was you saw some of the dynamics and how I approach it and why, and to make you think and go, that was the purpose of this. So that, again, this is an understanding of I'm doing this to make this integrate in better into the person. This is the key points that I see of what I do to identify these things, then set it such, then to again control the amount of adjustments after the fact. Sorry, Jim, carry on.
no, just anybody that's got some questions, go ahead and send them in. And
Great questions, everybody. And so I just took off the molar. We'll put the molar on this side as we're running out of time. Okay, so I'm going to review a little bit as we work and finish. Number one, no nerve into the denture teeth. Patient cannot feel them. Patient feels by the hydraulic pressure induced onto the ridge by said denture. So they learn to feel by hydraulics. If they say to you that the bite is heavy on the right side than the left, that's because the denture is hydraulically loading the one side more than the other, and that's how they're interpreting that. Okay. So it's kind of neat. You can kind of see as I just, before I even adjust the tooth, that lingual cusp is already sitting within the fossa. And then remember, I got to drop it back and then follow the wear pattern. And that's when it's starting to bind. So that's why then I'm going to color this. And then I'm going to try to mimic that chew cycle down there. And then you can see how it's right there. It's marked away right there on that guiding plane. So now I can adjust that out. Okay. So again, circling back to the review. They feel hydraulics, okay? And then there's a wear pattern. Understand that every person has a chew pattern, and then on natural teeth, I'm able to see that chew pattern by the wear pattern on their dentition. And then I can see that and then mimic that when I do the immediate. So that's looking actually pretty decent in there. And again, not knuckle tight, okay? The shear cusp overlapping, everything's there to help keep the food on the lower to bring it up to get crushed by the upper. And then all the cusps are there to work within that perceived chew cycle of that patient. Sorry, I dropped the 1x8 on the floor. Okay. Awesome. So that's my journey through a little bit of occlusion and an immediate. And again, I appreciate, wanted to again draw some similarities through all the different types of occlusion you're going to see on an immediate, but it tells you a story. Take a look and think, why does it look this way? And then how are we rehabilitating it? And then how can I set the denture teeth within what I'm thinking it's going to be and how we're rehabilitating it so that it integrates better for that person. That's the beauty here, okay? Because I never would have thought to take an articulator and actually, shove it back. So again, this one side, it's more protrusive when this person eats, so that everything needs to function for that person within that realm. And then again, you can see right there where, see, there's a contact. Whoops, that didn't focus well. Contact right there. And that's hitting right on that guiding, whoops, that guiding plane right there on the lower. So there we go. Cool, hey? So that's a little bit of my journey and how I've spent time to take a look at a patient and understand the patient and build dentures that are better integrated into the patient.
All right, so those of you that have emailed or let's see here, in your question box about CE, that'll be delivered. Give us a couple of days, we'll post that out and send you a letter if that's what's needed. It has been recorded, so if you want to go back and review, it will be posted on our VITA learning website, VITA North America, on our YouTube channel. This is a list of the people that can help you out from the company perspective, your local rep, as well as a help desk. And then we have one more remaining webinar left for the rest of the year. And then we'll start 2024. We'll start adding those into it. We have set up 2024 denture courses in VITA Germany, so there's going to be 2 of them. So if you want to join us, it'll be basically 2 days of training. The rest of the time is just fun. Going to a winery or going to a pub or a beer manufacturer, things like that, sightseeing. So that's a really good time if you're able to go during that time. Mark is gracious enough to provide everyone his information. If you have a follow-up question, you can email him or call him. Just remember, he is a practicing denturist and out lecturing, doing other things as well. So if he doesn't get back to you soon, right away, give him some slack. He'll get back to you as soon as he can. And then as far as last minute questions, after the denture is processed, how much undercut of the flanges would you remove?
Okay, that's a judgment call. Yeah, I try to take the undercuts out as much as possible and realistic. Remember, the surgeon's got to, or the dentist has to be able to put the thing in, and you have to try and facilitate that. And if they can't, then they're going to be grinding the denture to do it. I always like to say I'd rather grind the denture than the doctor because that's my wheelhouse. So as much as they would say, yeah, Mark, I don't want you, grinding on the natural teeth because that's not my wheelhouse. So yeah, you have to try to eliminate the undercuts, and it's a judgment call, and that's just time and experience. When you see the patient the next day and you see, did I relieve it enough, and you learn about tolerances. So yeah, you have to relieve it. Try not to shorten it if you don't have to. Try to really hollow it on the inside, but leave the length to help the seal and to help it kind of go up over top. That helps you out in the long run.
All right, and then if the long branch you guys not visible, what can you do?
Right. Then that's a problem. So if the long branch rugae is not visible, that's a problem. Yeah, you use the long branch rugae. So then you kind of have to look at the midline and go, okay, the upper would sit here, the lateral, excuse me, the upper central would sit here, the lateral here, the canine should be here. And again, it's always on the corner. So as you have the ridge and as it starts to curve and transition to the posterior, that's where the canine should go. So you can use some other visual cues if those rugae are not there. The rugae aren't there because they're compressed. Something happened that they're not there. They're usually quite visible for people.
Okay. And then do you normally remove the anterior teeth first, then the posteriors, or it's case dependent?
Case dependent. Again, it's where I saw the wear pattern. That's where I like to start with the tooth. So then I put the denture tooth within that same wear pattern, because then that lets me establish and be able to remember the chew cycle of that person. So you saw on what we just demoed, I left the central there. I did the lateral first because that was my cue, and that would taught me to, again, let the thing drift backwards. So I was careful to do that tooth first on that side to establish that so that I can then mimic it for the rest of the setup. So it changes.
Right.
Yeah.
Well, thanks, Mark. That
Awesome.
was great. There was a lot of great information. A lot of people had a lot of questions, and which is always good. And really appreciate you taking time out of your day to go over these things with the customer base. Any last minute comments you'd like to make to the group?
Well, yes, so thanks everyone for joining and taking a moment to learn and again to be a superhero. And as we share our stories, that's how we grow our profession, learn within our profession to be that superhero to our patients. So thank you to being open to that. And again, thank you to you, Jim, and to VITA North America for your support of our denture professions as we are trying to strive to be that superhero. So we're very grateful to the support of the company of VITA North America. And you and your team to put a lot of work into getting these organized. Thanks to everybody, and thank you for your questions. And if you need support after the fact, you can contact me personally, and I'll do my best to help you. So thank you for that. We're here to support each other, grow our profession, so that we continue to evolve to again, help people mince, mix, swallow. Because if this doesn't work, nothing else does.
Well, thanks, Mark, and thank you everyone for joining us today for another VITA Academy webinar.
Nice.
Wherever you may be, have a great day or evening, and we will see you next time. So this will end today's webinar. Bye,
Awesome.
everybody.
Thanks, everybody.